Hello, I'm Lucian Leap of the Harvard School of Public Health, and I want to talk to you about patient safety. Patient safety is freedom from harm caused by medical treatment. It's part of, but different from quality. One can think of quality and safety as the yin and yang of healthcare. Quality is about providing the right care for the patient. Safety is about doing it right. Quality is about effectiveness, appropriateness, and choice. Safety is about execution, skill, and preventing mistakes. Quality is about doing the right thing. Safety is about doing the right thing right. While quality and safety seem like very different characteristics, the methods we use for achieving them are exactly the same. We design care, each of the hundreds of processes of care, to make sure that each patient gets the right care in the right way 100% of the time. This idea of achieving quality and safety through how we design our work is a relatively new concept in healthcare. Until fairly recently, we relied on the knowledge, skills, and conscientiousness of doctors, nurses, and pharmacists to do the right thing and not make mistakes. But conscientious and competent doctors and nurses and pharmacists are humans too, and they forget and make mistakes like the rest of us. More about that in a minute. There are some other differences between quality and safety. Errors hurt people at the moment and are usually obvious. Quality failures take a bit longer and are often not clear-cut. The measure of quality is, did you help the patient? The measure of safety is, did you harm the patient? So it's not surprising that safety has more salience to patients. They may be vague about what quality is, but being hurt focuses the mind. Patients don't always expect you to make them better, but they do expect you not to make them worse. The organized effort in medicine to provide reliably safe care is not very old. The beginning of the patient safety movement can fairly be identified with the 1999 Institute of Medicine report, "To Err is Human." Its origins were in a large Harvard School of Public Health study done 10 years before that showed a significant number of patients in hospitals were harmed by errors and that as many as 100,000 people died every year because of these mistakes. A subsequent study published in 1994 showed that most of these errors could be prevented if healthcare systems were redesigned using principles from human factors engineering that make it easy for people to do something right and hard to do it wrong. So the IOM packaged the shocking number with a crucial message. These errors and these deaths were not caused by bad people, but by bad systems that led conscientious, competent doctors and nurses to make mistakes. Quit punishing people for making errors, the IOM said. Redesign your systems. So that's what we set out to do. But it turned out not to be easy. It's been a difficult journey, progressing so far through 4 phases. The first phase was the period of awareness, of shock and acceptance of the problem. Prior to the IOM report, neither the public nor the medical profession realized how serious the problem of harm caused by medical errors was. The IOM numbers were truly shocking and met by many with disbelief, particularly the medical profession. Because an individual's doctor's rate of serious error is low. Those 100,000 deaths were spread among 800,000 physicians. Any individual doctor could easily not see one in 10 or 15 years of practice. That made the huge numbers hard to believe. Medical leaders questioned the numbers. Academics wrote papers to show the studies were flawed. One including the curious claim that some deaths were in very sick patients who would have died anyway. But others began to look at their hospital results and found more harms than they had previously been aware of. Then other studies gradually appeared that found injury rates that were even higher than the IOM had proclaimed. Other countries replicated the American studies. They too found even higher rates of harm. The World Health Organization formed the World Alliance for Patient Safety. The era of shock and denial was over. people got to work. Which brings us to the second phase, which was widespread implementation of system changes. Hospitals began to look at their systems and figure out how they could redesign them. Prodded by the Institute of Healthcare Improvement and with a little funding from the government, researchers developed and tested new practices and innovations. Within a few years, the National Quality Forum had identified over 30 safe practices, evidence-based processes that hospitals should adopt to reduce errors and harm. In 2004, the Institute of Healthcare Improvement launched its 100,000 Lives campaign, enlisting 3,000 hospitals to implement 6 of the National Quality Forum safe practices. 2 years later, they had saved more than 122,000 lives. Major improvements were also made in medication systems with the introduction of computerized orders, unit dosing, barcoding, that substantially reduced medication errors. Peter Pronovost showed that perfect adherence to a protocol could completely eliminate central intravenous line infections. Later, with his help, 68 hospitals in Michigan completely eliminated central line infections and ventilator-associated pneumonia for more than 6 months. Atul Gawande showed that surgical complications and mortality could be substantially reduced by regular use of a simple checklist. But these were exceptions. Overall, progress has been slow, much too slow. It's been difficult to show we've made a difference. And as we've gained experience in changing our processes and systems, we began to realize how difficult it is to make the needed changes. This led to the third phase, teamwork and collaboration. A system is really a description of relationships, how we work with one another to achieve a certain goal. System change is therefore about changing behavior. It means that everyone who's involved in the process, every stakeholder, needs to do things differently. Stakeholders either buy into a change or they become an obstacle to it. The experiences of Pronovost and the IHI showed that achieving this behavior change requires people to collaborate and work in teams, goal-driven multidisciplinary teams. Teams succeed when every individual feels valued, respected, and personally responsible, when everyone has a voice and every voice is heard, when every opinion is respected, whether it's the doctors or an orderlies, nurses, or a patient's. Teams fail, and failure is much more common than success when those conditions are not met, when the prevailing culture works against mutual respect and cooperation. Which brings us to the fourth phase, culture change. In too many, perhaps most, healthcare organizations, the culture can fairly be described as dysfunctional. Most are still hierarchical and autocratic. Many workers at all levels are treated with disrespect and do not feel supported or appreciated. Highly trained professionals work side by side, but not together. This environment and these attitudes are not conducive to the team building and collaboration that is needed to make healthcare safe and bring joy and meaning to work. To develop the teamwork and collaboration needed to change our systems to make them safe, we need to create a culture of safety, a culture where safety truly is job one and transparency and honesty are core values, where no one is blamed for making an error, but everyone is held accountable to follow safe practices. A supportive culture where everyone is treated with respect and given the tools they need to improve. A culture where patients are engaged as equal partners in their care. Those are the system changes we need to make healthcare safe.